My name is Nima Nabavizadeh. I'm assistant professor here at Oregon Health and Science University Department of Radiation Medicine. I'm also the medical residency program director. And it's my honor today to talk to you guys about lymphoma and the role of radiation therapy for lymphoma. So an outline for um, our didactic session today. I'll start with a typical workup for a patient with lymphoma. Talk about staging and the diagnosis of lymphoma. Delve into a little bit the different subtypes of lymphoma. There's quite a few of them. We'll throughout this overview session, we'll talk about the typical treatment paradigms for both non-Hodgkin's lymphomas and Hodgkin's lymphomas. We'll go through a couple radiation case examples. We'll briefly touch on some special techniques for some special lymphomas, and then also um, discuss the toxicities of radiation therapy. So typical presentation for lymphoma is a painless enlargement of one or more lymph nodes. These nodes may feel rubbery and swollen when examined, and typically the cervical and supraclavicular lymph nodes are the most common in about 80-90% of patients who present. Splenomegaly presents in about 30% of the patients, but this enlargement is seldom massive like it is for patients with cirrhosis or portal hypertension. And the size of the spleen may fluctuate throughout the course of treatment for these patients. Systemic symptoms present in about a third of the patients. These consist of low-grade fevers, night sweats, unexplained weight loss, and that's at least 10% of the total body mass in 6 months or less. These constellation of symptoms used to previously be included in our staging algorithms for patients, where patients with who had A symptoms basically did not exhibit any of these, whereas patients who were marked to have B symptoms would present with fever, night sweats, or unexplained weight loss. In 2020, the A and B designations from our staging system has been removed, but this is important to know just for kind of historical reasons. Some patients present with pruritus due to increased levels of eosinophils systemically, and many patients present with fatigue. Um, a rare finding for patients with lymphoma is pain following alcohol consumption. I have yet to see this clinically in a patient, but definitely read about it many, many times. And classically, these involved nodes can be painful after alcohol consumption. And this is thought to be due to vasodilation. So typical history and physical exam for these patients, assessing smoking history is important. We talked about the B symptoms, alcohol-induced pain, pruritus, assessing their performance status, how functional they are, to what extent they take care of their activities of daily living is really important. Any history of prior radiation is important to collect from these patients. And then a thorough physical exam, including all clinically evident lymph node regions is extremely important, as is a abdominal exam assessing the size of the spleen and liver. Here's a cartoon of the different lymph node regions throughout the body. Some of them are bilateral, some of them are just kind of midline and single lymph node regions. So starting from the top, you have the Waldeyer's ring, which is kind of a constellation of the adenoid tonsils, the base of tongue, and the nasopharynx. And these lymph node regions play a great role in basically staging our patients with lymphoma. The diagnosis for lymphoma is typically done with an excisional biopsy. Unlike carcinomas where an FNA or fine needle aspirate can be sufficient, for us to make a good assessment of lymphoma and determine its subclassification, it's quite important to have the whole lymph node and the architecture of the lymph node available. Pathologists using, FNA might be able to say that there is a B cell neoplasm, but differentiating that from an Indolent low-grade lymphoma, like a marginal zone lymphoma from diffuse large B-cell lymphoma, can be very challenging with an FNA, and these excisional biopsies are greatly important. Sometimes we can get away with core biopsies, which is, is kind of in between an FNA and excisional, but excisional is still the standard for diagnostic evaluation of a abnormally large lymph node. Once biopsy has been confirmed. Oh, and one other thing to note is it's important not to start steroids on any patients for any symptomatic ailment, if possible, because corticosteroids can differentiate lymphomas and make them look nicer than they potentially are. So it's important to kind of wait until you get the excisional biopsy to start steroids, if you can. Obviously there are situations where um, you must start steroids quickly, but if you can hold off, I think it's a good idea. PET-CT is important for staging. Bone marrow biopsy is important for all non-Hodgkin's lymphomas. And for Hodgkin's lymphomas, if PET-CT does not show any bone marrow uptake, it's okay to omit it. Only for Hodgkin's lymphomas. And knowing whether or not bone marrow is involved is important for staging, which we'll talk about. There's basically a whole constellation of uh, lymphoma subtypes, and you can see this WHO classification, quite exhaustive. It's a very heterogeneous disease, and identifying specific subtypes is important because it dictates treatment and prognosis. So to further simplify this long, exhaustive list, this is a better way of thinking about it. Well, you have lymphoid neoplasms, and these can be split into three different groups. You have your non-Hodgkin's lymphomas, which include both B cell and T cell neoplasms, and you have your Hodgkin lymphomas. Here's a single slide on staging. This is basically an adaptation of the Ann Arbor staging for lymphomas, and it's quite simple actually. If a patient has only one group of lymph nodes involved, either above the diaphragm or below the diaphragm, they're classified as having stage 1 disease. Two or more lymph nodes on the same side of the diaphragm classify as stage 2 disease. So if this patient had lymph nodes here and lymph nodes here, he would also be called stage 2. Stage 3 is for patients that have lymph nodes on both sides of the diaphragm, but it does not yet involve any kind of solid organs or bone marrow. And patients are classified as having stage 4 whenever they have diffuse disease involving either bone marrow or solid organs such as the lung, liver. In addition to stage, it's important to classify patients as having bulky or not bulky disease. And historically and classically, and still we do this by assessing the this metric called the mediastinal to mass ratio. And basically what you do is you take the distance between the largest extent of the thorax on a PA chest film. You also take the distance of the largest region of the anterior mediastinal mass, and you divide this by this. And if it's over 33%, we classify somebody as having bulky disease, and that changes what we do, and really it brings radiation much more to the forefront of their treatment. Typically, these bulky classifications are done for large mediastinal masses, but if somebody has a very large mass outside of the mediastinum, say a 7.5 to 10 centimeter cervical lymph node or inguinal lymph node or external iliac lymph node, we will also use the bulky moniker for those patients as well. Outside of the thorax, there's debate whether 7.5 or 10 centimeters is the right size cutoff to classify somebody as bulky or not. To be safe, we usually use a 7.5 centimeter cutoff. For the B cell lymphomas, we can classify these in three different subclassifications where we have our indolent lymphomas. And for these indolent lymphomas, these are not as aggressive as the other ones. And radiation can be used as a cure by itself for early stage patients. Early stage meaning stage 1, stage 2 patients. Aggressive lymphomas constitute diffuse large B-cell lymphoma, mantle cell lymphoma. In these situations, radiation is used as consolidation following chemotherapy, or for localized disease, or for bulky disease, like we talked about, regardless of stage. And the highly aggressive lymphomas, or the Burkitt lymphomas, lymphoblastic lymphomas, the age-related non-Hodgkin's lymphomas, these are very aggressive, and their typical presentations are very advanced, and RT is rarely used in the curative setting here. And it must be noted that RT is used widely for local symptom palliation. So for the low-grade non-Hodgkin's lymphomas, those are the indolent lymphomas that we talked about, the ones right here on the left side. We can further divide these into early stage patients or advanced stage patients. Like I mentioned earlier, early stage patients can be cured with radiation alone. For the advanced stage patients, we need to determine whether they're having symptoms or not. We also need to determine whether they're having cytopenias or not. This is because the primary treatment for these patients, the backbone of treatment is chemotherapy. And we really don't have any great data that starting chemotherapy now is better than starting chemotherapy later once symptoms may arise. These patients can have, survivals with their disease of decades. So it's important to weigh quality of life into any kind of um, treatment plan for these patients. And quite commonly, patients with stage 4 disease who are feeling fine without any symptoms, medical oncology routinely recommends close observation with chemotherapy initiated anytime they're having any cytopenias or any symptoms from their disease. For the high-grade lymphomas or the more aggressive lymphomas, there's a whole algorithm of assessing their immunophenotype to figure out what subtype they are. And again, this is really important. Once you get to the kind of Burkitt lymphoma realm, you're talking about very dose-intensive chemotherapy as compared to diffuse large B-cell lymphoma, where the chemotherapy regimen and the radiation regimen are quite tolerable, and disease outcomes are quite favorable. Again, unlike Burkitt lymphoma. And in between the two, we have these lymphomas that are considered double hit lymphomas or triple hit lymphomas, and these are patients that have translocations on FISH of either MYC and BCL2 or MYC or BCL6, or for triple hit lymphomas, it's MYC, BCL2, and BCL6. These are all very prognostically important patients that are double or triple hit, meaning they have these translocations of these genes. They have much more aggressive disease. Their prognosis is much worse, and we talk about dose escalating their chemo much more than the non-double hit or triple hit lymphomas. This is just a quick snapshot of the histology and immunophenotype of these high-grade B-cell lymphomas. And you can see the exhaustive immunohistochemistry done on all these slides, and this kind of just shows why having a lot of tissue is important, because they are rigorously tested to determine exact subclassification that can dictate treatment. There are two prognostic scales that help us educate patients and ourselves how well a patient will do with their lymphomas. There's one scale, prognostic index called FLIPI, or Follicular Lymphoma International Prognostic Index, and then there's one for the large cell or more aggressive lymphomas, the IPI. And each one of them have distinct point systems for various clinical parameters. And when you add them all up, you can get 5 and 10-year overall survivals for these patients. So you can see patients who are less than 6 years old, who have early stage diffuse large aggressive lymphoma, good performance status, you know, um, no extranodal involvement, meaning no involvement of lymphoma outside of lymph nodes, who also have the normal serum LDH. They have a great 5-year overall survival of 75% after treatment. And this is in comparison to older patients with more advanced disease who, unfortunately don't do as well. So this is your classic. So moving on from non-Hodgkin's lymphomas to Hodgkin's lymphomas. Here's your classic Reed-Sternberg cell, the owl eyes, showing the large atypical lymphocyte, which is pathognomonic for Hodgkin's lymphoma. Owl eyes. There's two subtypes of Hodgkin's lymphoma. There's classical, and then there's non-classical, or non-classical is also called nodular lymphocyte predominant Hodgkin's lymphoma. For the classical Hodgkin's lymphomas, they are marked by being CD15 and CD30 positive. This is unlike non-Hodgkin's lymphomas that are not CD15 or 30 positive. Um, for the non-classical lymphomas, they actually have immunohistochemistry more consistent with Hodgkin's lymphomas, um, yet they exhibit the Reed-Sternberg cells that make them pathognomonic for Hodgkin's. So, this immunophenotype discrepancy is what separates these classical lymphomas from these non-classical Hodgkin's lymphomas. And then the classical lymphomas are further divided out into subtypes based on what they look like on H&E and with immunohistochemistry. And as far as treatment, these subtypes of classical lymphomas, Hodgkin's lymphomas, don't really change what we do regarding treatment. There are some that are prognostically better than others, um, but still we treat all these classical Hodgkin's lymphomas the same, and we treat them with combined modality chemotherapy and radiation in the early stage setting. In comparison, these non-classical lymphomas, or nodular lymphocyte predominant Hodgkin's lymphomas, we can actually treat with radiation alone in the early stage setting, and only in the advanced stage setting for those non-classical Hodgkin's lymphomas do we bring in chemotherapy. And as far as distinct histopathology, we talked about the Reed-Sternberg cells. We also talked about, or the nodular lymphocyte predominant Hodgkin's lymphomas also present with these large pale staining multi-lobe cells that we call the popcorn cells. So here's just kind of an example of what typical treatment for stage 1 classical Hodgkin lymphoma looks like. So this is a patient who's, usually relatively young, who presents with abnormal lymph nodes in the neck. In this early stage situation, stage 1, typical treatment usually consists of ABVD chemotherapy for 2 cycles to start off with. And ABVD is a cocktail of adriamycin, bleomycin, vinblastine, and dacarbazine. After those 2 cycles of chemotherapy, we then restage the patients with PET-CT. If on PET-CT they have a complete response, we'll consolidate this treatment with involved site radiation to 20 gray. We'll talk about more what involved site radiation refers to. However, if the patient has a partial response, we'll probably give them more chemo, 2 more cycles, and restage with another PET-CT. And if everything looks good and they're in a complete response after the 4 cycles of chemo, we'll do involved site typically at 30 gray and potentially boost higher if there is a partial response to chemotherapy. And standardly for all lymphomas, we do a restaging PET-CT, or what we call an end of therapy PET-CT, about 8 weeks after treatment. So that's for Hodgkin's lymphoma. For non-Hodgkin's lymphoma, and more specifically diffuse large B-cell lymphoma, we treat these also with combined modality therapy. And treatment here typically consists of R-CHOP chemotherapy followed by involved site radiation therapy. This is a typo, I apologize. This should be involved site radiation therapy. And the R-CHOP chemotherapy consists of rituximab, which is a monoclonal antibody to CD20, cyclophosphamide, doxorubicin, vincristine, and prednisone. In these combined modality settings, we usually give 3 cycles of this chemotherapy, then restage with a PET. Everything looks good. We consolidate the areas of initially involved disease with radiation therapy to 30 gray. Like I mentioned earlier, disease outcomes can be graded using the IPI. And for younger patients with not very advanced disease, their outcomes are pretty good. So just to summarize again, radiation is important therapy for many lymphoid neoplasms. Uh, like we talked about, it can be used as definitive therapy by itself for either early stage non-aggressive or indolent B-cell lymphomas, and can also be used as curative monotherapy for non-classical Hodgkin's lymphomas. Those are those ones that have popcorn cells. Um, Radiation is used as consolidated therapy for early stage high grade B cell lymphomas, such as the I just showed you guys. But we also use it commonly to eradicate disease for patients who present with bulky disease, again, large mediastinal masses or very large lymph nodes outside of the mediastinum, or for patients who have initial bony involvement. Radiation is an important adjunct here because these patients with either bulky disease or bony involvement, even in the advanced setting, we have evidence that shows that if their tumors do come back, the lymphomas do come back, they tend to come back more often in these bulky sites or these bony sites. And that's why radiation is used as an adjunct quite commonly for these patients. Um, in the Hodgkin's lymphoma situation, we use uh, radiation therapy after chemotherapy in the definitive setting, what we call combined modality therapy. For patients who have very unfortunate recurrent or chemorefractory disease, we're typically talking about doing a autologous bone marrow transplant. And on the way to a bone marrow transplant, we want to make people as close to being in complete remission as possible. We want them to go into transplant with very, very, very low volume disease. And to get patients there, particularly the ones who have chemorefractory disease, we'll bring in radiation in the peri-transplant setting to basically get them to that remission situation. And then radiation, low doses of which can be used for palliation for all types of lymphomas. Here's a diagram of the evolution of radiation therapy for lymphoma. 40, 50 years ago, we treated radiation kind of like chemotherapy, meaning we also because our chemotherapy wasn't as good as it is today, we treated many lymph node regions with high doses of radiation, comparatively speaking. So this TNI refers to total nodal irradiation, something we pretty much never do anymore, which is basically irradiation of every single lymph node region. And over time, we've whittled away at both the volumes of radiation as well as the dose of radiation. So, these cartoons can represent one patient, or one example of a patient with stage 1 Hodgkin's lymphoma who presented with isolated disease in the neck, 40 years ago, 30 years ago, 20 years ago, and today. And this is the kind of iteration we've gone through. We've gone through this iteration because we've learned much more about lymphoma. We have chemotherapy that's much more effective. And, we've also whittled away at our dose because lymphoma is a very radiosensitive disease. There are two types of cell death with radiation, either apoptosis or necrosis. Typically, with carcinomas, we're going for a necrotic death where we damage the cell membrane integrity and cause an inflammatory reaction, and that requires higher doses than an apoptotic death, which is what we see most commonly with lymphomas. And with that, we see minimal inflammatory infiltrate. We see involution and apoptosis, profound apoptosis of the cells from relatively low doses. And the ranges that we're in today for consolidative radiation for patients who've had complete response to chemotherapy for either Hodgkin's or non-Hodgkin's lymphoma, 20 to 30-ish gray of radiation, that's about half of the total amount of dose somebody with, head and neck cancer or lung cancer or cervical cancer gets. So it really speaks to the exquisite radiosensitivity of lymphoma therapy that makes these treatments much more tolerable. Now in 2020, we are treating with a concept called involved site radiation therapy to lower doses, and we'll talk about that. So when I was in training 7, 8 years ago, commonly we were still talking about involved field radiation therapy. And this refers to radiation therapy of the whole cervical lymph node region. So a patient might present with one lymph node here, and our radiation volume consisted of the whole cervical lymph node region, cervical lymph nodes from levels 1 down to 5 in superclav. Um, Obviously, this is a radiation of much more tissue, and we've kind of whittled away at that to this concept of involved site radiation therapy. And for involved site radiation therapy, we take into account pre-chemo and post-chemo information and treat the region that was initially involved with an added safety margin. So for contouring purposes, we have something called the GTV, or the gross tumor volume. And for all of our lymphoma patients, we contour a pre-chemotherapy gross tumor volume and a post-chemotherapy gross tumor volume. So it's almost standard that patients' PET scans and imaging will look much different after chemotherapy for lymphoma. So we have to take both these pieces of information into account when we're developing the radiation volumes. The clinical tumor volume encompasses the original gross tumor volume, um, and we basically, this is kind of the added safety margin of the normal tissue that we're contouring for treatment. It's important in these situations with the clinical tumor volume to crop out any normal tissue that is no longer clearly involved. Meaning, if a patient had a very, very large mediastinal mass, patient had a very large mediastinal mass, 10 centimeter mediastinal mass, your pre-chemotherapy volume would be huge. They've went through a lot of chemotherapy, and that mediastinal mass is much smaller now. What we need to do in involved site radiation therapy is make sure that we're cropping out that normal lung that has now filled in the void where that tumor used to be, because obviously we don't want to radiate all that lung tissue. So our volume post-chemotherapy is going to be much smaller, and this needs to be incorporated into the CTV. And then a PTV is basically just an additional daily setup margin. Um, Depending on the disease site, we're treating 0.3 to 1 centimeters. Here's some examples of some next CTVs. This is a patient with a left cervical um, lymphoma. And this red volume here is the involved site radiation volume. So it takes into account where the disease initially was, which is bracketed in there by the yellow, with an added, basically, clinical safety margin of making sure we're encompassing any microscopic residual disease. And here's a patient with a mediastinal tumor. Um, and this is a diagram showing the benefit of a deep inspirational breath hold for patients who are treating mediastinal lymphomas for. Cardiotoxicity is a major issue with any type of thoracic radiation. And for patients with upper mediastinal tumors, we'll have them take a deep breath in and hold their breath while we treat. And what this does is it pulls their heart inferiorly, and as you can see on the image on the right, and basically removes the cardiac tissue from our radiation volume, drastically decreasing the heart dose. I want to touch on a couple special topics. One is cutaneous T-cell lymphomas. These are also called mycosis fungoides. Um, these are cutaneous lymphomas that typically present as either focal or diffuse disease. Standardly, many of my patients have been misdiagnosed for years um, until they finally receive their diagnosis of cutaneous T-cell lymphoma. These patients can also present with advanced presentations that are systemic, and Sézary cells refer to these circulating um, T-cell lymphomas within the plasma. There are a multitude of treatments for patients with cutaneous T-cell lymphomas, and these treatments can be divided into either skin-directed therapies or systemic therapies. And obviously, with radiation therapy, we come into play with the skin-directed therapies. Here's an example of a patient of mine who presented after years of misdiagnosis with this angry, painful right wrist cutaneous T-cell lymphoma. Very ulcerative, very painful. Thankfully she was left-handed, um, but still, as you can tell, this was a huge burden for her. Given the exquisite radiosensitivity of lymphoma that we discussed, the profound apoptosis we see with even the lowest doses of radiation, we delivered two fractions or two treatments of radiation, 4 gray each, which is a relatively low dose of radiation with really no side effects, no erythema, no burning. And you can see the dramatic response this patient had. The image on the left is 2 weeks after low dose radiation. And the 8-week image, she lives on the coast and thankfully sent me some images. You can see she's had more or less a complete response to radiation therapy. Very exciting. She's extremely happy. For patients that have more diffuse disease, more diffuse cutaneous T-cell lymphoma, obviously, we can't do focused treatment like we did of that previous patient, and we need to deliver radiation more diffusely throughout all skin surfaces. And we do this with a concept called total skin electron beam therapy. And basically, patients, instead of laying on the table like they do for most all of our radiation treatments, they stand along the wall and they rotate through 6 different positions. They call it the Stanford positions. Um, that basically ensures that they receive a homogeneous radiation dose throughout all skin surfaces. And the top right image, you can see this patient in one of those positions, and the linear accelerator is delivering superficial electron beams that basically bathe her skin with radiation dose. And similarly to other radiation subtypes, we've whittled away at the dose. Historically, we treated these patients with 30 gray or more radiation total skin, which came with a lot of severe long-term side effects, fibrosis and anhidrosis, which is quite bothersome. Now we're able to get really, really good responses with low doses or relatively low doses of radiation, anywhere from 8 to 12 gray of radiation. And if patients do develop recurrent disease, we still have a lot of room to deliver more radiation therapy, and this treatment is very, very effective. Um, you can see there's some places of the body that are shielded from these radiation treatments, and one of those locations are the soles of the feet. So if a patient presents with disease on the soles, this type of total skin electron beam therapy will not deliver adequate doses or any dose to the soles of the feet, obviously, because they're standing on it, the machine can't see it. So in those situations, we do focal boosts, like you see in the bottom right, to various places of the body that have bothersome disease that are shielded. So typical areas where we might consider boosts that are shadowed from total skin are the soles, like this patient, perineal regions, inframammary regions for females. For larger patients, um, uh, regions underneath their penis might need additional focal boosts of radiation, as well as vertex scalp. The vertex scalp doesn't get a great dose. So for the toxicity of radiation, for all radiation treatments, there's short-term and long-term toxicities. Since lymphoma develops in almost all parts of the body and all organs, most all of the toxicities are disease site specific, obviously. So for patients who have head and neck lymphomas, we talk about mucositis, taste changes, esophagitis. For patients who have cutaneous lymphomas, we talk about erythema. For patients with abdominal lymphomas, nausea, vomiting, diarrhea are possible short-term side effects. There are also long-term side effects of radiation, infertility, xerostomia for those head and neck patients, cataracts, and then I'll highlight briefly the risks of cardiotoxicity and secondary malignancies. So this is a large registry study of about 15,000, I believe, patients who are childhood cancer survivors. And you can see the comparison of anthracyclines, which is a common used medication for common use chemotherapy for both Hodgkin's and non-Hodgkin's lymphoma. And here's radiation in these right charts. Um, it's clear that both anthracyclines and radiation therapy put patients at risk for cardiac disease, whether that's cardiac congestive heart failure, pericardial disease, valvular disease. Um, and with radiation therapy, the more dose the heart has received, the higher the risk of these complications. And for the doses that we typically are seeing, somewhere between the 15 to 5 to 35 gray for patients with mediastinal disease potentially. Um, it's tough to say that the incidence of um, cardiovascular disease from radiation is really any worse than anthracycline. So in the early stage 1 settings, there's two paradigms that people typically treat patients with. You can either do R-CHOP for 3 cycles followed by radiation, or you can maximize the chemotherapy over 6 cycles and not give radiation therapy. And looking at this, looking at these charts, at our tumor board, we take it on a patient by patient basis. If we think that the morbidity and toxicity of radiation outweighs the morbidity and toxicity of anthracycline, we'll talk about doing R-CHOP for 6 cycles alone and hope that they have a complete response. For patients who have, maybe maybe isolated nodal disease in very accessible regions of the body with low morbidity, we'll talk about doing a combined modality approach with 3 cycles of R-CHOP, limiting them the extra toxicity of the anthracyclines, but then adding in the radiation to regions where we can safely do so. And then for young women who present with mediastinal axillary tumors, we always talk about the risk of breast cancer long term. Again, our goal for all these patients is to create long-term survivors, and weighing the risk of breast cancer with the benefits of radiation therapy are very important. And you can see on the graph to the left from this JCU article in 2009 that the younger you are, the increased incidence of breast cancer you have, at 25 years out, the yellow curve on the left, somewhere around a 20% cumulative incidence risk of breast cancer as compared to, the population risk, which is somewhere around a couple percentage point at 20 years. Um, And then on the graph on the right, you can see that with the decrease of our volume from the mantle fields, mantle field refers to a radiation field that encompasses the mediastinum, the supraclavicular regions, and the axilla. You're obviously radiating a lot of breast tissue with that type of volume, which we rarely do anymore. You can see the risks of breast cancer are quite greater than they are for patients who are getting just mediastinal radiation alone, almost twofold greater. Interestingly, you can see for patients who had both mantle field and pelvic radiation, so these are patients who were treated many years ago with total nodal irradiation, their risk of breast cancer are actually less than the risk of breast cancer for patients who had mediastinal irradiation and no pelvic RT, that blue line there. And you might ask yourself why that is. That's probably because the pelvic radiation ablated any estrogen production that they had remaining. And without estrogen, the incidence of breast cancer for those patients and the driver for breast cancer was absent. So their cumulative incidence of breast cancer was less than the patients who received mediastinal radiation but no pelvic radiation. So obviously, radiation volumes, larger radiation volumes, increase women's risk for breast cancer. So in conclusion, radiation is important therapy for many lymphoid neoplasms. Like we mentioned earlier, it can be used as definitive monotherapy for patients with early stage indolent or non-aggressive B-cell lymphomas, such as follicular or marginal zone lymphomas. And it can also be used as definitive monotherapy for non-classical Hodgkin's lymphomas. Those are the nodular lymphocyte predominant Hodgkin's lymphomas. We use it as consolidative therapy for early stage high-grade B-cell lymphomas or diffuse large B-cell lymphomas. Or we use it for all stages for patients who present with either bulky disease or bony involvement to prevent relapses or recurrences at those sites. We use radiation therapy as definitive therapy following chemotherapy for early stage classical Hodgkin's lymphoma patients. We also bring it in the peri-transplant setting to consolidate patients who may have either recurrent or chemorefractory disease. And like I showed you with our patient example, low dose radiation is extremely effective for palliation of symptoms. Involved site radiation in 2020 is a standard of care for RT volumes. And the low doses that we're able to utilize can confirm short-term tolerability, but the long-term adverse events of radiation need to be discussed with patients, and that's mainly in the in the case of cardiotoxicities and secondary malignancies. Thank you guys for listening.